So to start us off, Dr. Arjun Segel is an international clinical and research leader in the field of high precision stereotactic radiation to the brain and spine for both metastases and primary tumors. Trained at the University of Toronto in radiation oncology, he completed a radiosurgery fellowship at the University of California in San Francisco. Dr. Segel has published as lead or as a contributor to over 400 peer-reviewed papers, including high-impact journals such as the Journal of Clinical Oncology, Lancet Oncology, and the New England Journal of Medicine. Dr. Segel is currently the lead, of the Sunnybrook Odette CNS Neuro-Oncology Program. Awarded a total of $42.5 million in funding since his leadership. Currently, he serves as the Deputy Chief of the Department of Radiation Oncology at the University of Toronto, affiliated with Sunnybrook Odette Cancer Centre. In addition, he is the director of the Sunnybrook Cancer Ablation Therapy Program, which involved the installation of the MR brachytherapy suite, the MR-Linac, and the Gamma Knife Icon technology. I've had the pleasure of working with Dr. Segel for over a decade now. Holy moly, Arjun! I have to say, you've always been willing to jump on, to give a presentation, to help out with a resource, to present at an event for us. So we thank you again for joining us today. And I also want to mention that Dr. Segel is the very first healthcare professional here in Canada who's received a healthcare professional award from us at Brain Tumor Foundation of Canada just this past November. So congrats on that award. And Dr. Segel's presentation, as you can see by the title here, is MR-Linac for brain tumors from inception to clinical reality. So thank you, Arjun, for joining us today. And I'll just let you take it over from here.
Well, wonderful. And thank you very much for the introduction and for the Healthcare Professional Award. That was an especially touching event for me and my family. So thank you for that. And it's a real great pleasure to talk to you about the MR-Linac for brain tumors, because it really is a story of bringing a novel technology for our patients with brain tumors, so they don't get ignored amongst the mix of all the cancers that could be treated on novel technology. We really have made an effort to bring this for patients with brain tumors. So what is the MR-Linac? Well, first of all, what it is for the first time, we've been able to integrate a high field strength MRI like you would normally get for your normal diagnostic imaging and getting an MRI of the brain. But now we can actually get the MRI each day while we're delivering the radiation. So we have merged the technology of a linear accelerator with an MRI, and this represents really a feat in radiation technology and just medical engineering that we've been able to do this. So it really is a novel device for patients with cancer needing radiation. But who are we, and how did this come about? And it really came about as a result of the University of Utrecht in the Netherlands that built the prototype. And then in collaboration with the vendor Electa, they formed and they decided to take this product, develop it, and bring it to market. But it didn't happen on its own, and it happened with this global MR-Linac consortium. So there are various centers from around the world, including the MD Anderson in Texas, Netherlands Cancer Institute in Madison in the United States, the Royal Marsden, the Christie in the UK, and Sunnybrook as the only Canadian site that was involved in the genesis of the technology. And our role, because we're known as global experts in the treatment of brain tumors, was to develop it for the central nervous system. And all of these different organizations had a key site that they wanted to develop. And certainly for me and my team here, it was about brain tumors. So what's our journey look like? Well, in 2013, we joined as a founding member of the MR-Linac Consortium. We did a lot of work in terms of understanding the technology, the limitations, and how to actually make it happen. And ultimately, the first units were made. And this resulted in a lot of construction. And I spent just as much time treating patients as in the construction site because it was a new thing that we had to make sure went smoothly. And together, we eventually in 2017 delivered the gantry, which is this huge piece of steel that went through the ceiling of the Odette Cancer Centre, and then did the testing. Ultimately, we got the clinical system, we had imaged the first patient, Health Canada approval, and in August 2019, I'm proud to say, we treated the first patient who was a patient with a glioblastoma. Now, when you talk about developing a new technology, you have to have a framework because you just don't want to go off without a plan. And we actually developed a plan through the consortium of different stages of technology assessment that brings it to the clinic. And how do we make this an actual treatment for all patients with brain tumors in the future? Well, this is the roadmap that we go to systematically evaluate the technology so that we make sure that a new technology, such as the MR-Linac, actually benefits patients with brain tumors, because it may not be something that we need to do, and it is an extra. Not all patients can be treated with it. And our goal was to make sure that if we are going to go through CNS tumors as an application, to do it in a smart way and study it systematically. So I'm going to show you some of that roadmap and all the work that we've done, because we've treated now almost 140 patients. Well, when you look at the MR-Linac program, it involves several steps, from the treatment planning evaluation to the imaging, to only using MRI now instead of a CT, and adaptive planning. But ultimately, we want to get onto a clinical protocol that will change the future of radiation applications for patients. So what were some of the fundamental first steps? Well, one of the fundamental first steps, and the reason why it took so long to get an MR-Linac or to deliver radiation in the magnetic field, is what we are all worried about is this effect called the electron reverse effect. So if you can see here in the top with a B off, these red lines are the electrons going through the tissue. Now, what happens is when you turn the magnetic field on, which is called B on, you see this curling that happens in those little red squiggly lines. And that's called the electron reverse effect. And what it does, if you look at the bottom in this beam's eye view of a dose map, is it blurs it. And on the graphs on your left are some of the effects of the electron reverse effect, which you can see at the end. This peak goes up. And everybody was worried about this because it's an uncertainty. And in radiation oncology, we do not like uncertainty. But can this effect be mitigated? And as computational power increases, can we model this and make it safe to deliver? So some of the initial work was actually done by my fellow at the time, Eric Sang, who's now on staff with me. And I said, you know what, go learn this in Utrecht and figure it out for brain tumors, because they were really the pioneers of the technology. And he went there as part of his fellowship. And we did some work in terms of understanding the ability to treat a brain lesion with the MR-Linac. And what we found was really, by the software being so good now, we can mitigate that effect of the electron reverse effect, understand it, and then account for it. So it's not as much of a clinical issue. And where we were worried about it was in air cavities and the skin. And again, by modeling the data and coming up with software solutions, it's not really much of an issue. So this provided the evidence for us to say, okay, well, we think we're going to be okay and we're going to be safe, and we have a framework. But where do we want to test it in? And really what we need to test it in is patients with glioblastoma, because as you know, or as many of you have experienced, the standard of care is still temozolomide with radiation. And really there's been no advance since the pioneering papers now more than a decade ago, which proved the benefit of temozolomide. But as a radiation oncologist, because we're delivering that initial 6 weeks of radiation and getting you through a very tough time of treatment, is that we really were in the dark. We have an MRI that we do at baseline at the time of planning, and then we do it about a month or two after the radiation's been done. And for those of you who have gone through the process, you ask, well, how's it going? And we're like, oh, I would think you're doing okay. But we never had any objective imaging data to say, oh, your treatment's going all right. Things are going okay. Let's reduce the dexamethasone. The tumor's getting smaller. Oh, no, the tumor may be getting a little bit bigger, and maybe that's inflammation. And as patients, this is an aspect of the treatment delivery that you're demanding, and we could not give that to you, but now we can. So it started out with actually starting to image patients during treatment. And there was only a handful of centers around the world that have really investigated doing MRIs during radiation. So with Sten Meyerhag, who's one of also my faculty here in my group as a radiation oncologist, we started looking at day 10 and day 20 MRIs in addition to the 1 month. So you get a baseline, You get about a third the way through, you get an MRI, 2/3 the way through, you get an MRI, and then after. And you're going through standard treatment in terms of the linear accelerator. So we wanted to see, well, is there an actual benefit to trying MR-Linac therapy? Because if the tumor doesn't migrate, or if everything stays stable, well, then there's probably no point, because the head doesn't move, as opposed to a prostate or a pancreas where it's always moving. And maybe that's where the money is for an MR-Linac. But what we observed here was eye-opening. So what you can see here in this graph, or in this image of the brain tumor in the white, is the baseline kind of area that we need to zap. And then what we see at day 10 and day 20, you can see that tumor is migrating and changing, and actually migrating to the other side of the brain. And we're adapting now and changing the radiation map to account for this, that we would have never otherwise known. And in the bottom, what you can see here is there are different quadrants of changes. So the volume can increase, but it can stay stable. The volume can decrease and stay stable, or there can be a combination of migration of the tumor, say, to the other side of the brain with different volume changes. So in actuality, about 30 to 40% time, we're now making a clinical decision based on these data in terms of reducing medications, adjusting medications, or even changing the radiation map. So this was eye-opening data that we published on almost, I think, about 61 patients with full-blown imaging capacity. And this is one of the largest series in the literature. So now we've shown, okay, we can certainly take you offline and take you into an MR and do the imaging and perform the analysis and change, but our aim is actually to look at daily images. So what are those daily images going to look like? Because the MR-Linac MR is not the same, because don't forget, it actually has a linear accelerator in it. So that changes some of the properties of the MRI. And we started first with some voluntary imaging. So once we got it in here, some patients of ours kindly agreed to go into the MR-Linac and get some images while we were doing a lot of that fundamental work before it got Health Canada approved. And we saw that the image quality was very nice. And we started acquiring different images, and we were very comfortable with that. And in fact, we have 2 scientists dedicated to improving the images on the MR-Linac, because it's a brand new MRI for the world. So this is an example now of a patient who actually went through weekly imaging. And you can see here, things are okay. And then what you'll see is a bright white flash, and then things are kind of changing and adjusting. And that was a little bit of hemorrhage that we would not otherwise have known. So we're learning, and we continue to learn. So now that we've been able to do some imaging on the MR-Linac, we've got weekly imaging, we're happy with it. Now we have to think about how we're going to treat the patient, because we're still waiting for Health Canada approval. So now we're developing our workflows, and it's all about workflows. How are we going to make sure that when you come for your treatment, or your loved one comes for your treatment, everything goes smoothly, and there's no guessing games in radiation oncology. I mean, radiation is serious business. It's a treatment that we cannot take back, and it can cause harm. So we've been working on these workflows. So patients come in for your regular CT scan, you get your MRI. How are we going to draw or contour the volume that we want? And then what is the radiation map going to look like? And then every day when you go through treatment, how are we going to evaluate to make sure that that radiation is being delivered with the same accuracy and precision as normal? So we've made through those workflows, and we've published these workflows so that people can adopt them, and we can take the patient ultimately on to treatment. So one of those steps also was actually looking at a new treatment planning system. So this is a very different way for us to evaluate and to understand the radiation that's being delivered. And one of the beauties of the MR-Linac is the treatment planning system is one of the most sophisticated dose calculation algorithms that are out there. And basically what that means is that it models the actual impact of the radiation better than we knew before. And it's just different. So in the old way of doing things, which was the pinnacle, we can see things are very nice and smooth. And then with the extra information that we learn by using the MR-Linac software, and that increase in the ability to know exactly what's happening at the electron, so right at the fundamental level of the dose deposition, we started seeing a little bit of differences in some different areas of radiation delivery, which are a little bit concerning for us because we weren't used to it. Now it's all safe, but it's just not the way that we were used to it. So we had to understand this, and we've been doing treatment planning studies, but eventually we understood it and we were comfortable with it, and we can get going. And my new fellow actually is looking at this in a systematic way to publish these data, because it is different. And with every advance, we see differences. So now we have the patient onto treatment. So now this is a brand new world for us. So we're actually getting imaging every day. And these are some images during the course of treatment where we get our normal T1. Now, for those of you who are familiar with MRIs and going through this process, we don't give the dye because we're not going to give the dye every day. So we are certainly dependent on the non-dye images, but the flare that tells you the swelling of the brain, we can monitor without dye. And you can see here some beautiful, nice responses with less swelling of the brain as time goes on. And we can do some functional imaging. So now looking at the cellular makeup of the tumor, and we'll get into this a little bit later, but there is real potential for us to understand the biology of what's happening to tumors and feedback to the patients, such as yourselves. But one of the challenges, so when you have all this data and images, is that we actually have to be able to get the information out of the image in the area that we want. So while we spend all that time drawing exactly where we want the radiation to go, we can't do that every day. I mean, it takes us hours to do this. So we can't do it for 30 treatments per patient. That's an enormous amount of workload. But luckily, computing software is able now to do a lot of the work for us. And this is what we call contour propagation. So again, evaluating the software to automatically take what we did and put it on each new MRI so that we can extract the information. And we saw here really reliability of the software in order to do this in the brain tumor patients. And now we're able to do very sophisticated ways of what we call contour propagation. And we do see some differences, you know, when we see from day to day, just because of the difference in position, that the fact that we can now adjust on a day-to-day basis is making things even safer for delivery. So we understand better what's happening day to day in the radiation delivery so that we know that we're always hitting the target, but also safely. So this is just an example of some of the variation that we're seeing on a day-to-day basis in terms of some of the dose points. Now, most of it all hover around 0, but you could see some increases or differences in the actual dose delivered on each day. And these differences were initially somewhat alarming for us because we are not used to understanding this information. But what was good about this when we did what we call dose accumulation is that we were able to see that it all kind of smoothens out. And by the end of the treatment, it is pretty much exactly what we expected. So those little minor variations are really not impacting the overall delivery when you take into account the full 6 weeks of radiation that's delivered. And this is an example of the reference plan, which you can see here on your top left, variation at day 4, day 11. But by the end of it, when you sum all the radiation per day, it actually looks really quite beautiful in terms of what we're delivering and pretty much exactly what we expect. So again, more reassurance and better understanding of what we're doing. So in terms of treatment, I mean, this is just telling us that what we've been doing for years is great. What we can do with the MR-Linac in terms of treatment planning is safe, but we do need to move further into the future. And this is where we come into advanced imaging and this and also metabolic imaging. And we'll talk about this as well, because one of the big research domains that we have here is called chemical exchange saturation transfer imaging. And we're lucky to have the Sunnybrook Research Institute, which is one of the most premier imaging institutes in the world, actually developing advanced metabolic sequences. So actually looking at the metabolism of the tumor. And we've been able to find in brain metastases, which was first. So that's when cancer has spread, say, from the lung to the liver. And then we're trying to treat these individual areas in the brain, that we've been able to segregate responders from non-responders. So based on the molecular information of the tumor, we can tell you how you're going to do and what that further follow-up imaging likely reflects, which is tumor response or tumor progression. But we wanted to apply this to glioblastoma because, as you know, this is very different. We're talking about 6 weeks of radiation, and we have to make sure that what we're doing is of value so that over time during those 6 weeks, we are seeing response. Because if you're not responding, then we should switch the gears and do something else, maybe different chemotherapy, maybe different surgery. But the first step is to understand, because going through that 6 weeks is so tough for you guys and our patients, and we get you through treatment, but you want to make sure that you're going through it for value. And there are some patients where you will see progression early on. And how do we know who that is? Well, this is some type of imaging that's going to tell us, and our preliminary data were published showing that we can actually determine progressors from non-progressors very early on during treatment. Now, another form of metabolic imaging is called magnetic transferase. So again, interrogating the biology of the tumor. And again, we're seeing some responses. And again, these are on our normal MRIs. And we need to translate this actually to the MR-Linac. Now, one of the challenges that we had was that most of those very advanced images are done on a 3 Tesla MRI. So that's a very strong strength MRI that really pounds the brain in terms of the magnetic field to get the information. But almost everything we do is on a 1.5 Tesla MRI, and that's the same strength as the MR-Linac. Now, our MR Sim, so we actually have a dedicated MRI to image brain tumor patients for treatment planning. Well, we had to actually figure out how we were going to do all that advanced imaging on a 1.5 Tesla MRI. So Angus Lau and Rachel Chan, our scientists that are working the program, actually took apart the MRI, fiddled with the electronics, did some patching, and lo and behold, even though it was a bit risky and they warned us, the cancer center may blow up, just kidding, we were able to actually adopt functional imaging on a 1.5 Tesla MRI. So that's the first step, and that's a big step. And we published that actual ability in a very prestigious journal because this is the first of its kind. So how are we doing? Even though you can do it, is it actually doing anything? So these are some data showing the CEST response imaging. So the yellow here is the high CEST signal. And what you can see here in a non-responder, that yellow signal is really persisting. But in the responder, so someone who's actually kind of the tumor biologically is getting more inert, it may not be shrinking, but its actual metabolism is shutting down, you don't see as much yellow in there, and you're starting to see different colors. And ultimately, we're able to segregate a non-responder in red from a responder in blue. And we're early on, but we're understanding this and we're getting better and better. Now, there are lots of different imaging out there, and if you do reading or if you're aware of this, one of the more mainstream ways of doing image assessment is called perfusion imaging. So this is looking at the blood flow. And you can do this on many different MRIs. Even a lower strength MRI is not an issue because this is not as sophisticated in terms of looking at the cellular architecture. So we've published these data just very recently, and Pejman Marlani, our expert neuroradiologist here at Sunnybrook, looked at the data on 38 patients that had gone through our process. Again, understanding all of the factors associated with the tumor, including the surgical extent, but also the molecular extent. So if you're MGMT positive, if you're IDH positive or IGH negative, these are all IDH negative, and segregating into early progressors versus late progressors. So what did we find? Well, we found that using a very simplified model of understanding the blood flow through the tumor and the area surrounding the surgical site, we can actually predict response. So again, the theme here is trying to use advanced imaging to understand who is going to do better than not, because it's so important for our patients to have a realistic expectation of how they're going to do when we're talking about an incurable cancer. And there's some patients that are going to do better, and there's some patients that will not. And now we can help inform not only the patient, but the family and everybody so that they understand what's happening to their disease. And these are just some data showing that these metrics can actually segregate patients in terms of who we can expect may not live as long as somebody who may live really quite a longer period of time. So again, going back to the MR-Linac now, again, remember this MRI is not the same, even it's a 1.5 Tesla MRI, but it's a different design because there's a radiation unit that's jammed in the middle of it. So we actually have to now go back and try and do these on the MR-Linac. And this is how complicated it is. And this is why we're so dependent on grants and philanthropy and support. And we've had support also from the Brain Tumor Foundation of Canada to perform these experiments and understand what we're doing. And I'm very happy to say that we've been able to do this on the MR-Linac. And this is just an example of an advanced MRI map. So this is called multiparametric imaging. So you can see we have the T1, a FLAIR, a T1 map, T2 map, all of these different types of imaging that are really interrogating the tumor area that's resected, but also the region around the tumor, because we always have to treat a volume or area of the brain to try and kill as much microscopic disease that we can't see. And by doing this type of imaging, we may be able to see that microscopic disease that you couldn't otherwise because we're using advanced metabolic or cellular imaging. And some of the challenges that we've had really run around time. And for many of you, I mean, going to an MRI is not pleasant for anybody, but you're talking about 45 minutes or an hour. And now you're telling me I got to go for radiation, but while I'm getting radiation, I've got 45 minutes of imaging. No, we're tailoring that down. So this is an example of a process map. This is how we tailor the amount of imaging for just what you need, and also develop or build in some research sequences so we can do better in the future. So overall, from start to finish, it is about 40 minutes. Now, on a standard linear accelerator or radiation unit, you can come in now, in and out with it in about 5 to 10 minutes. You know, it really is incredible the speed at which we can deliver radiation with using normal units. But with an MR linear accelerator, we're not there yet. It's still early. But what you get is the benefit of a daily MRI. And for a brain tumor patient, I would argue that that's extremely important because we're always looking at the tumor on MRI. There are other sites of disease where we don't use MRI almost ever, but now that is changing also as a result of the technology. Now, some of the really cool things that we're doing is also called a functional imaging. So we're actually testing the ability to determine what areas of the brain are active in different types of tumors, like a glioblastoma or a meningioma, and what's happening during that radiation. And do patients with a glioblastoma, is there connectivity in the brain different than, say, somebody with a meningioma or a benign tumor? And can we model that? Because say we could find areas of connectivity that matter that are in the radiation field, maybe I'll adapt the radiation field to save some of those areas of connectivity that could mean better functional outcomes, say better thinking outcomes or better processing outcomes in terms of brain function. So very early, but very interesting data that we have been acquiring as a result of the MR-Linac. So how have we done thus far? Well, I'll tell you, we've done pretty good. We've treated now 115 patients. 42 minutes is the average session time. And just in terms of the actual core time, it's about 22 minutes, but start to end, about 42 minutes. And you can see here, there's a breakdown of all our imaging, and it has been a very successful program. Now, we do this not only in terms of our research program, but we're sharing our data within that consortium. As I mentioned before, we were one of seven in the world, and now we're sharing our data all together as part of the Momentum study. So everybody who goes on the MR-Linac, because it's new, goes on a clinical trial, and we share that information. But what I'll show you here is this dash, the blue line here, which is brain tumors, so the blue dotted line here, we're getting pretty high up to even lymph nodes or prostate cancer. As a result of our program, we are one of the dominant indications now being treated with the MR-Linac. And why that's important is it pushes the field to develop it globally for patients with brain tumors so they can realize this technology. Otherwise, some tumors just get left out because people don't have the desire to develop the technology for the indication. But that's not what we do here. We are dedicated to brain tumor patients. So how are we going to get into the future? So we can treat, and we're doing it in a standard way, we're learning, but but our aim is to change the paradigm to make the treatment better for our patients. So there are different ways of dealing with this. So one is that, we're seeing different changes in the brain. Sometimes we're seeing different tumors actually pop up in terms of glioblastoma, seeing other areas of the brain being affected that we wouldn't otherwise know. We can see a reduction in swelling or increase in swelling, and that can make us change the dexamethasone. And for those of you who know, dexamethasone is always the drug we're trying to get you off of, because it is good at reducing swelling, but it has a lot of negative impacts in terms of how you feel and on the body physiology. And then there's the idea of putting it all together, getting that biologic information and really doing things smarter, because we may not need to treat as much normal brain tissue. And there are some data looking at actually very active areas. So using some of that diffusion imaging or IVM imaging, and then finding out where is active and maybe actually hitting that area harder. And at University of Michigan, they've been doing it with standard MRIs, not necessarily changing it on a day-to-day. So they're assuming the static nature of it, taking some MRIs during treatment, but hitting it very hard in selected areas. And this is really where we want to go, which is biologically informed tumor targeting. Now, at Stanford, what they did recently was they took a 6-week course of radiation in very selected patients, and they cut it down to 5 days. And it is a huge departure when we do that. And that's called hypofractionated radiosurgery. I don't think necessarily it applies to all patients, and we have to be very careful in terms of how we did it, but do that. But what's important here is that they reduced that margin to 5 millimeters, where we normally use 1.5 centimeters or 15 millimeters. So we are taking this approach with the Michigan approach, and we want to do better. But first, we have to make sure we're all drawing the same, because it requires international cooperation, and we standardize how we draw our volumes for radiation amongst the consortium. And Eric Sang led this work, so that was an important first step in terms of consensus. And now we're trying to figure out also how the tumor spreads. And this is just some work where we're using advanced imaging known as radiomics to actually predict where the tumor is going to grow. And maybe that's an area that we also have to concentrate that extra radiation boost on. So this is work in development as well. And ultimately, we're talking about the UNITED trial. And this is unity-based MR-Linac guided adaptive radiotherapy for high-grade glioma. So it's a phase 2 clinical trial, which we hope to open in the next few months, 40 patients, treating with either 6 weeks or 3 weeks if you're older than 65. And we'll have daily MR imaging with adaptation using a 5 millimeter margin, and using all that information to try and define as much of that volume that we need to include and include it. And then adapting the radiation on a week-to-week basis so that we ensure that we're hitting the targets as much as we can. And ultimately, where we will go is more refined volumes, but this is a first big step. And this is a major step for the field. But we're not only about there in terms of one step further, we want to go even further. And this is even further in the future. And this is where our focused ultrasound program comes in. So we're one of the first in the world, or the first in the world, to open the blood-brain barrier with an MRI-based device. And we're actually showing that we can get chemotherapy into tumors that we could never do before in some patients with brain metastases. For example, in this case, with breast cancer, we're seeing Herceptin now lighting up in the tumor, which we would not have otherwise penetrated. So very exciting work, which we ultimately want to bring to the paradigm of the 6 weeks of radiation, inducing some focused ultrasound, doing the MR-Linac as well, doing things smarter, and hopefully improving outcomes of survival. And we want people to live longer as a result of all of this technology and doing things better. So I would say in conclusion, there are huge applications for the MR-Linac in brain tumor patients. We can't be left out of novel technology, as our mission is to make the standard of care treatment better for patients' life. The future is completely open to innovation, and I'm really hoping maybe next year come back and show you that we were able to do at least the first major step in improving patients' life with advanced radiation technology. With that, I would say thank you very much and hand it over back to Jenny.
Thank you so much, Dr. Segel. That was, as always, a very informative presentation. Can you remind me, as currently right now, Sunnybrook is the only hospital in Canada that has the MR-Linac, correct?
So there are a few hospitals that have it already, but we are
Okay.
the only hospital actually treating brain tumor patients. We're actually probably only two in North America. There's Madison, Wisconsin, but we are the brain tumor site for the global consortium.
Okay. And so somebody was asking from Quebec if there was a hospital in Quebec that had the equipment yet.
Not yet. I know that they've been trying to install one in Shum, but not yet. But there are
Okay.
plans. There are plans, I believe.
Okay, great. So I just have a few questions if you have a couple minutes.
Sure.
So one person asked, would the MR-Linac be effective for an inoperable grade 2 or 3 oligodendroglioma?
Sure. The application of the technology is to any brain tumor. Now, the question is, would it change the prognosis by not operating? And I would say no. The first step is still a proper operation.
Mhm.
The aim here is to make the radiation component of that treatment better, and it might.
Right, perfect. And is it available for recurring glioblastoma? It is. I think you
Yeah, so
mentioned
it
that,
is.
right?
So our protocol right now is really in the upfront setting, not in the recurrent, because you don't need to use such big margins on the recurrent. And our aim is margin reduction. So when you don't need to have a big margin because you're dealing with a recurrent tumor, I wouldn't think that it's appropriate. And remember, you're going through 45 minutes a day, so we have to
Right.
be careful.
Right. Okay, perfect. Thank you. I'm just looking at the other questions that came through. It says, to date, what stage of glioblastoma treatment is the MR-Linac most successful, and is the genetic makeup of the tumor important to its success?
That's a great question. So we're certainly seeing by day 10 a lot of changes that may allow us to do some adaptation. Okay. By day 20, we're really understanding better who's going to respond and who's not. So the entire program is giving us a wealth of information. So
Mhm.
I would say that, we don't know yet in particular what's ideal, and we're studying it.
Mhm.
And the genetic makeup of it is actually really interesting, because on one hand, you could say that if you do have some of the favorable markers, you may benefit more because we're able to volume reduce and do things better. But also, if you have very aggressive tumor, we may be able to hit it harder and
Mhm.
give you that extra dose, which may matter. And so I think it's applicable to all patients with brain tumors.
Mhm. Okay, perfect. Thank you. Another question that came through was just the comparing the MR-Linac to the Gamma knife stereotactic radiosurgery.
Perfect. Great question. So always, and this is a recurring question, the gamma knife is really for metastases or small tumors where you only need to hit the target. In glioma, you need to treat a region of the brain. Now we're trying to reduce that region that needs to be irradiated, but it's not for a radiosurgery treatment. That can be used in the recurrence, but not in the upfront.
Okay, perfect. And what about comparison to proton therapy?
So proton therapy is very interesting. It doesn't use the same image guidance. So it doesn't, not an MR guidance.
Mhm.
The real only advantage for proton radiotherapy is some of the low doses, which are not clinically consequential. There was a randomized phase 2 study done at the MD Anderson for glioblastoma that did not realize benefits for protons. And it's because you don't need it, in that technology. There are some areas, but we can safely treat and with the same dose of radiation as a proton unit. But here now we have MR guidance, and now we're able to track and monitor the tumor, and that may realize benefits rather than a very similar technology that's been around for 100 years. So there are actually data that says not really applicable.
Okay, perfect. Thank you. Just looking through here. How could this technology improve lesion identification for patients with MS and astrocytomas?
So, that's a really interesting
Yeah.
question. So I would say that, so if somebody has a concurrent diagnosis of MS and a primary brain tumor, we're pretty sure we know exactly where that tumor is.
Mhm.
MS plaques look very different. So I wouldn't say that that is necessarily an application, but just you need proper imaging and you
Mhm.
need a neuroradiologist to help you delineate exactly where you want to treat, because
Mhm.
MS plaques are identifiable.
I'm just curious, as my co-presenter, can you see the questions as well?
Yes, I
I'm
can.
just curious,
Yeah, I
just
can
from a
see.
learning perspective. So this one here is MR-Linac for glioblastoma only, or also used with meningioma patients too, which you mentioned before is glioma only.
Right, so
correct?
we have done some meningiomas and we have done some tumors, benign tumors, really while we were ramping up. But you don't see a lot of change. So there's some critical meningiomas that are right near an organ at risk that I will do it for. But the main issue here is glioma because the
Mhm.
brain is changing and it's inflaming and it's contracting, and we're able to see that, which you wouldn't necessarily see with a benign tumor.
Okay, perfect. And just a couple more questions here. I'm wondering if there's been work undertaken in the genomics area to help identify who might respond better to the treatment before embarking.
Yeah, that's a wonderful. And so, in collaboration with our surgical scientists, we are actually interrogating with next generation sequencing these patients that we put on the study. So, we're hoping by doing next generation sequencing, we can actually give you that answer. And I'm hoping in about a year from now, we will be able to do that.
Perfect, thank you. And do you know quite yet what the criteria is going to be for that clinical trial, or?
So it's newly diagnosed brain tumor patients who are elderly or younger, and
Mhm.
I would say that in terms of our criteria and the philosophy of care, I would say that certainly um, our belief is that where the big gain is going to come in terms of survival is going to be with new drug therapies.
Mhm.
So
Mhm.
if we don't have a new drug therapy, then certainly we would want to try and make the radiation better.
Mhm.
And this would be a very good alternative clinical trial for newly diagnosed brain tumor patients. But I would still say that if there is a chance to get on a new drug and have that integrated into the care, that would be our priority number one, at least here at Sunnybrook. And then we look at technological types of innovations to improve
Mhm.
care.
Okay, perfect. And just one last question. I'm not sure if you can answer this or not, but this person said that they were diagnosed with a grade 3 anaplastic astrocytoma, IDH mutant, diagnosed in April 2020. This person was not offered the MR-Linac from Princess Margaret Hospital at the time, and the usual tradition radiation method was used. Just wondering why possibly they weren't offered the more advanced treatment at Sunnybrook.
Well, look, at the end of the day, we're right now investigational, so it's all a clinical trial. So it's the standard of care is still the standard of care until we prove that it's better. We can't say that it's better. We
Mhm.
can only infer from what we're learning right now.
Mhm.
Hopefully, in the future, it does become the standard of care, and we do see centers using the technology for it
Mhm.
because we believe in it.
Yep. Perfect. Thank you. And somebody mentioned that they would like to make a donation directly to the project itself at Sunnybrook. So maybe you.
Yeah, you can always get in touch with the Sunnybrook Foundation, and they will certainly direct it to the program. And you can always direct it to the Gord Downey
Right.
tumor program because James Perry and I treated him, and it,
Mhm.
it was a phenomenal experience, but one that we were very grateful for him to establish that brain tumor foundation program within Sunnybrook.
Perfect. Thank you so much, Dr. Segel. I think that's the majority of the questions. If anybody, if I didn't get to your question, my apologies. We're still kind of this new platform is new to us. But if I missed your question, just let me know in the chat, and I can follow up with Dr. Segel via email with your question. As always, Dr. Segel, so great to see you. I miss visiting you and the team at Sunnybrook Hospital and running up and down the halls with you guys and saying hello to everybody. So please say hello to everyone. Maybe a virtual high five or virtual hug. We see that you're in your scrubs, so I'm sure that you are ready to hit the ground running again this afternoon. So thank you. Just know that there's over 100 people online with us today, and I'm sure they're all clapping for you in your presentation for your team and all the work that you're doing. So, and yes, we would be happy to have you back anytime for any updates down the road. So we're going to switch over to Jody's presentation, and thank you again. Really appreciate it.